and we're here because we're doing science differently, and we're trying to speed up getting great drugs to patients. And I wanted to start by sharing a little story with you. This morning, I got my Utah driver's license. So I'm 18 months into Recursion, and I just moved to Utah in October. And I've been putting off getting my driver's license because, well, DMV, right? But the DMV here is lovely, I have to say. But what occurred to me as I was walking out of the DMV was that I had kind of an identity shift where all of a sudden I took on this new identity, that I was a Utahn officially, and I can vote in the upcoming elections, and I can contribute in meaningful ways. And that made me think about the identities that we all have. And you might be asking yourself, why me? Why am I kicking off this amazing rare disease community and the discussions that we're going to have today? And so I wanted to share with you another factor of my identity, and that's as a parent of a child with a rare disease. This is the impromptu whiteboard. You don't really have to read it, it's okay. Of the pediatric ICU at Children's Colorado Hospital. This was about a week after my son had emergency brain surgery. And the doctor was furiously writing on the whiteboard, on the wall, actually, this was the window of the ICU, to try to get me and my husband to understand what was going on. And essentially, she was saying, it's a tumor, it has I&I loss, it's SMARC1B deficient. None of that made any sense to me. I am a political scientist by training. And we came to find out that my son had a type of rare pediatric cancer called ATRT, atypical teratoid rhabdoid tumor. This is a cancer that usually presents somewhere between birth and 18 months, and most children die by the time they're 3 or 4 years old. My son was 17 when he was diagnosed. He was one of 5 adults in the United States in 2023 when he was diagnosed. And I thought, oh, like, we're gonna beat the odds here. There should be lots of science, there should be a lot of medicine. I was very naive about this journey, and I know that many of you know this journey far better than I do. So I've had a rapid education in rare disease. This is my son, Finn. This is Finn after a couple cycles of radiation and chemotherapy. And I'm here tonight because I want to help in any way that I can. And I got really sick of people saying that they were sending their hopes and prayers, or sending strength, or sending me energy. And I bet you all have been in those shoes, maybe for yourself or for family members or for colleagues. And it's all great, but it doesn't do anything. Makes you feel a little bit better. But what is inspiring about all of you is that you are in it, that you are doing something, that you are advocating, you are researching, you are raising money, you are finding cures. And I'm grateful for all of you for doing that. My son, Finn, died 8 months after diagnosis when he was 18. There wasn't a single drug that could save him. And that was brutal as a parent, And I decided at that moment that there wasn't anything more I could do other than go into a company that I felt like was gonna try to change that for other families. And so that's my journey here. I'm here in honor of my son, Finn. He was amazing. He was vibrant. You can hopefully see that coming across in the pictures. And while my story might be different than yours, I know you all are here because you have a close connection. And I am grateful for that. And here among us, creating community is powerful for us going through our journey, reaching out and finding other parents that had children with ATRT, finding organizations that were running clinical trials. There just has been a data registration that has kicked off to try to do a lot of kind of virtual cohorts for trials for ATRT. So really interesting things happening. And there's a lot of you who are going to share tonight, so I'm going to wrap this up and hand it over. But just again, really grateful for you to be here and grateful for you to be in community tonight. And so with that, I'm going to welcome up Ava and Oskar. You can do it.
I didn't know. I'm gonna wait till my mom sits down. Yeah. Okay. Good evening. My name is Ava Szajnuk. I'm an undiagnosed rare disease patient. I'm here to briefly share a little about my journey along with my brother Oskar. First, I wanted to say thank you to everyone here tonight. It means a lot to our family to have all of you share in this special evening. We are so blessed to have so many Utah rare disease stakeholders, rare and undiagnosed patients, caregivers, and families here tonight. We want to give a special thank you to Recursion for hosting us again for our 4th annual Evening of Hope. We truly appreciate your continued support of our family and our entire rare and undiagnosed community. My family started the Rare and Undiagnosed Network, a 501c3 nonprofit, in 2014. My parents are the co-founders, and my siblings and I are all members of the advisory board. All 3 of us children, including my younger sister, Lucy, as well as my mom, suffer from undiagnosed rare diseases. We have been on a diagnostic odyssey for over 18 years now, starting with my mom when she gave birth to me at age 34. It continued with me at age 3, escalating into 4 cranial surgeries and a shunt implant at the age of 6. Oskar started having symptoms at 2 years old, while Lucy started even earlier at 18 months. We have over 60 syndromes and diagnoses between my mom, me, and my siblings, but no root cause, no treatment, and no cure. Doctors told my parents that they were the perfect storm and that they should not have a 4th child. The kicker is that my sister, my brother, and I also have polycystic kidney disease and will need transplants in our lifetime. That comes from my dad. The silver lining is that my father also had a kidney transplant from PKD almost 2 years ago now, and he's doing really well. I am now at the transition between childhood and adulthood. A lot has changed since I was 6, but a lot has also stayed the same. I still feel like the same kid who was always in a hospital room, even though those visits have mostly stalled now. Not because we found the answers, but because our family's energy is better spent on the positive. I've applied to all my colleges and am now in that bittersweet limbo period of waiting to find out where I'll be for the next 4 years. I feel as uncertain about the future as I was 12 years ago, but now that uncertainty comes with hope rather than fear. That hope originates in this community. I found solidarity in conversation, in exchanging stories of overwhelming symptoms, and in bonding over the maze that is the medical system. I've met kids who hold fast to their humor, curiosity, and childhood, refusing to be reduced to a diagnosis. I've talked with parents who, much like mine, stay strong in the face of their child's illness, even when dealing with their own. Many of these people are in this room right now. You have all taught me that true identity is the humanity outside of our diagnoses, the identity that endures when it is independently claimed rather than assigned by a medical label. The strength all of you show has also led me to what I want to do with my life, amplify underrepresented voices through policy and activism. With the help of these annual Rare Disease Day events and the newfound guidance from being the youngest member of the Rare Disease Advisory Council, I've discovered the power of using individualism to build collectivism. This community has encouraged me to chase not what my circumstances dictate, but what I choose to become. Through you, I have learned that a label is not the maximum for us, but the minimum. This is my love letter to the rare disease community. Thank you for showing me that strength does not always have to be loud, that sometimes resilience means getting out of bed even when the whole world is weighing on you. Thank you for showing me that the most powerful form of resistance is showing up for the people in your community. And thank you for embracing us with all the love in the world for the past 11 years. Thank you for once again giving me the space to share my family's experiences among people who not only understand our struggles, but lift us up in the midst of them. I would now like for you to hear from my younger brother, Oskar.
Hi, My name is Oskar Ava Szajnuk. I recognize a lot of faces here tonight, but I also see a lot of new ones. Thank you again for joining us. We are excited to celebrate RUN's 11th Rare Disease Day anniversary. RUN was founded in November 2014. We celebrated our first Rare Disease Day event with the Utah Rare Coalition and RUN's MBA initiative with the Utah Jazz back in 2015. We cannot believe how time has flown by, but there is still a lot of work to be done. RUN has evolved over the years to celebrate the Utah Rare, RUN's MBA initiative, and Utah Rare Disease Advisory Council, and again here tonight with Recursion. Our journey has taken us on such a special path. We have met so many people, wonderful people, and feel blessed to call them our RUN family, many of which are in this room tonight. We appreciate your continued love and support. As Ava mentioned, my diagnostic odyssey began around 2 years old. It started with intense leg pain and redness in my arms and legs. I would fall asleep at events and while eating meals. We were living in Chicago at the time. We went through every possible specialist, which eventually led to oncology for the leg pain. When it wasn't leukemia, we found ourselves at a dead end. Despite the 14 years that have passed since then, we've only come inches, not miles, towards finding a diagnosis. As I grew older, that leg pain disappeared. My fatigue didn't. My only medicine is sleep. As I get hours and hours of sleep, but I stay exhausted. Some schools I went to didn't fully recognize that because of the nature of being undiagnosed. But we did eventually figure out a system for me to attend school, which involved cutting out the first period of my day to allow me to get more rest. It helps enough to be functional, but it cuts into my largest personal problem with being sick. I want to fit in. That's hard when you show up to school an hour late, are missing 2 entire classes, and are constantly taking weeks off school at a time because of how easily you catch diseases and how hard they hit you. I haven't fully gotten over that fear of being different, but I know it's nothing to be ashamed of. In the closing of doors that being rare and undiagnosed did to me, it opened a lot more. If I was an average person with no remarkable medical traits, I wouldn't be here to support so many other people who I admire for their strength. I think RUN is an amazing foundation, and nobody should be ashamed of what they can't control. And like Ava, I am deeply grateful for everyone here allowing me and her and everyone else to share what they've been through. Thank you.
Yeah, we have one more thing. Lastly, we just wanted to share about the very special evening we had this past Saturday on Rare Disease Day. As most of you know, my father is the general manager of the Utah Jazz. We feel so blessed for the continued support Ryan and Ashley Smith and the entire Jazz organization have given our family all of these years as we joined them in 2013. The Miller family was also very supportive of our family. We came to Utah when I was 6 years old, Oscar was 4 years old, and Lucy was only 2. Utah is our home, and the Jazz are our family. So this past Saturday was a moment in time that we will cherish forever. The Utah Jazz recognized Rare Disease Day during a special pregame ceremony. The event highlighted the work our family does through RUN and RUN's NBA initiative. They also recognized the work of the Utah Rare Disease Advisory Council. During the ceremony, Governor Cox officially declared February 28, 2026 as Rare Disease Day in Utah. I would like to end with what that moment in time meant to us and our rare disease and undiagnosed community. It's an honor to play in the NBA. Success at this level requires extraordinary dedication, perseverance, and heart. In many ways, that same determination is reflected in children and families navigating rare and undiagnosed genetic conditions. While their journey looks very different from a basketball court, they show up every day with courage and resilience. For them, the court may be the 4 walls of a hospital room, an emergency room, a classroom, or their own home. Too often, their lives become a medical odyssey filled with uncertainty and challenges. This moment helps shine a light on their strength, raise awareness of their fight, and remind them that they are not alone. We stand together in hope of brighter, healthier futures for all of you. We hope you know how much light and love we feel from all of you. To learn more about our journey, please visit our website at www.rareundiagnosed.org. Thank you again for being here tonight.
Well, I think it's really unfair to ask me to follow Erika, Oskar, and Ava. That's we should have put you last, but me first, and it would have just gotten better. So, my name is Kelvyn Cullimore. I'm the president and CEO of BioUtah. For those who may be new to our organization here, BioUtah is, excuse me, is a trade association and common voice for Utah's life sciences industry. Approximately 1,600 medical device companies, diagnostic, biotech, and biopharma companies that together contribute more than $22 billion to our state's economy, more than tourism does, and employs 180,000 Utahns. We're home to some of the most cutting-edge discoveries related to a host of challenging conditions, including heart disease, cancer, neurodegenerative disease, chronic inflammatory diseases, infectious disease, genetic rare diseases, and more. On behalf of the Utah Department of Health and Human Services, BioUtah also administers the Utah Rare Disease Advisory Council, or RDAC. It's an honor to serve in that role, and Justine Case will have more to share about the RDAC's work shortly. What a fitting place, though, to gather tonight. We're here at Recursion Pharmaceuticals, a company born right here in Salt Lake that uses artificial intelligence to decode biology and discover new medicines for rare diseases and beyond. We also have ARUP Laboratories with us this evening. ARUP is accelerating the next generation of diagnostics that are guiding optimal treatment decisions for patients. That kind of commitment and innovation happening in our own backyard is exactly why tonight matters. I'm also excited to share, as already been mentioned, that the proclamation for Rare Disease Day issued by Governor Cox. If you didn't see it, it's right here. We appreciate the governor's support and the special Rare Disease Day presentation he gave on Saturday evening as part of a jazz pregame event with the rare disease community. And thanks to the Szajnuk family for making that happen. That was fun. The governor's not alone. Our legislature is also taking steps to acknowledge the rare disease community. Senator Todd Weiler and Representative Ariel DeFay proposed concurrent resolution regarding pediatric care for autonomic disorders. The resolution was approved unanimously by the Utah Senate and the House Health and Human Services Committee, and now awaits approval by the full House. The resolution encourages the medical community to increase awareness of, education about, and diagnosis of postural orthostatic tachycardia syndrome, or POTS, and related autonomic disorders, particularly in children and adolescents. It also encourages insurers to provide appropriate coverage to address the gaps in access to diagnosis and treatment of POTS. As the father of a daughter who deals with the symptoms of POTS every day, there is nothing I wouldn't give a cure for. While the level of POTS diagnosis may now take it out of the realm of rare disease, it is nonetheless indication of rising levels of awareness. In other words, awareness of rare disease is becoming less rare. The work of the Rare Disease Advisory Council is making a difference in raising the level of awareness, and I personally commend the efforts of this volunteer group, driven totally by a passion to find a cure and raise awareness of the daily challenges of the rare disease community. The collegiality born of a common foe binds this group in a strong and unique way. If there's one message I want to leave with you tonight, it's this. Our goal as an industry is to turn this evening of hope into a lifetime of good health. Hope is powerful. It's what brings us together in this room, but hope alone is not enough. Patients and their families deserve answers. They deserve treatments. They deserve cures. And that is what our industry is working toward every single day. Our industry sees itself as an essential partner of the rare and undiagnosed disease community. Consider the landscape. Globally, more than 300 million people are living with a rare disease. Over 10,000 rare conditions have been identified, yet fewer than 500 have approved treatments. Those numbers can feel overwhelming, but here's what gives me confidence. In 2023, the FDA approved 55 novel drugs, with a high proportion of these new therapies designated as orphan drugs to treat rare diseases. That's progress. Last year, Congress corrected a flaw in the Inflation Reduction Act that limited the ability of drug companies to find multiple indications for a rare disease drug. And this year, President Trump signed the new law, the Give Kids a Chance Act, to accelerate pediatric cancer treatments and expand access to therapies for rare diseases. Just a week ago, the FDA launched a framework for accelerating development of individual therapies for ultra-rare diseases. The draft guidance focuses on therapies that target a specific genetic, cellular, or molecular abnormality and are designed to correct or modify the underlying cause of disease. It provides guidance for sponsors seeking approval for the targeted individualized therapies by generating substantial evidence of effectiveness and safety when randomized controlled trials are not feasible due to the small patient populations. That is progress targeting the rare disease population. But despite these advances, more than 90% of rare disease patients still lack a treatment. That's why we can't afford to slow down. And here's what I want you to know. The greatest source of inspiration for our industry is not a technology or a molecule, it's you. Not just them, but all of you. It's the patients and families in this room who face challenges most people cannot fathom and who face them with the strength, love, and tenacity that gives rise to this day. You give rise to long nights in the research laboratory and ultimately to the breakthroughs that are changing medicine. So I leave you with this. BioUtah and our industry are on this journey with you. Not just tonight, not every day, but every day. We are committed to pushing the boundaries of innovation, to advocating for policies that accelerate the development and delivery of treatments, and to make sure that the voices of rare and undiagnosed disease patients and families are heard where decisions are made. Together, let's make sure this evening of hope is just the beginning of a lifetime of good health. For so many patients, their families, and their communities, let's just keep working together. Thank you. And now we'll hear from my good friend, Andy Robertson, Executive Director of BioHive.
Most of us didn't wake up one morning and decide to become experts in rare diseases. Most of us didn't choose this path, but it's the path that we're on together. My name is Andy Robertson with BioHive, and we're building, branding, and bringing together our life sciences ecosystem here in Utah. I've got to make it clear, I haven't walked in your shoes. I don't know exactly what you're going through, but I will tell you who I do walk alongside. We walk alongside inventors, entrepreneurs, drug hunters, people that are working hard to make a difference. This is my second Rare Disease Advisory Council meeting, and the resilience that I see is incredibly uplifting. The families that I hear about at this meeting are extraordinary. The medical knowledge that you've learned, the cures, the treatments, the knowledge, the verbiage, the meetings that you've gone through, it's extraordinary. You're not alone. The families are just part of what we do. We also walk alongside you as drug hunters, as an industry committed to making a difference for you, with you, alongside you. Thank you so much for the opportunity to be with you today, to be with BioUtah. We walk alongside you, and we're looking forward to the next meeting to hear about more breakthroughs, more treatments, more great news. Thank you so much.
Good evening. My name is Justine Case. I'm a patient member of the Utah Rare Disease Advisory Council. I am a graduate student in social work at Boise State University, and I'm currently doing my clinical internship in social work with the Traeger Institute of Optimal Aging at the University of Louisville, Kentucky. I'd like to start by thanking Gina Zanuck and her leadership in the RDAC, as well as her organizing run, working with Recursion for these last 4 years to create this event. I'd like to recognize also Governor Spencer Cox for honoring Rare Disease Day through the state proclamation, and BioUtah for administering the RDAC. So what is an RDAC and what does it do? We exist in order to help bring the voices of Utah's rare disease patient to our state policymakers. We were created in 2020 by the state legislature after several years of advocacy by multiple individuals and organizations. According to statute, we are made up of patients, caregivers, representatives from specific rare disease organizations that are doing advocacy in the community, physicians and researchers, and at least one representative from the Department of Health and Human Services. Here in Utah, all RDAC members are volunteers. If you are a member of the RDAC and you're here right now, would you stand up so our audience can see who we all are? We've got Januel in the back. He is seated with his wheelchair, so he'll not be standing, but everybody else, thank you very much for being here tonight. And I just want to emphasize that we are all volunteers. And I also want to cover just briefly what is a rare disease. Some of these statistics have already been covered, so I just want to emphasize rare diseases, when you put them all together, affect 1 in 10 Americans. And we are all experiencing very similar barriers to care. So I think it's really important, especially in doing policy work, to focus on that it's really not so rare. I personally live with 6 different rare diagnoses in this body right here in front of you. In my family tree, there are 10 more. And I don't mean 10 people who have what I have, though there are people who have what I have in my family. I mean 10 more rare disorders in my family tree. So I had signs and symptoms of my primary diagnosis since I was the age of 6, but nobody picked up on it. When I was in my 30s, I was prescribed medication that was contraindicated, and that initiated a catastrophic health decline. This photo of me and my daughter laughing in the woods was the last hike she and I enjoyed before I lost motor control of my legs for the first time. That became a normal event for me. It would come along with horrific nerve pain flares and would last for weeks and months at a time. After a year or so of screenings for Parkinson's and MS, leukemia, myasthenia gravis, brain cancers, my doctors let me know that they didn't think I was dying and they did not know what I had. I was mostly bedbound with nerve pain and recurring injuries from daily dislocations of my shoulders, my ribs, my spine, and occasionally my femurs. I was trapped in truly disabling pain, brain fog, and fatigue. Without a diagnosis, my insurance at that time refused to cover mobility aids, forearm crutches, the wheelchair that's in that photograph, physical therapy, which was the only thing that gave me any amount of relief from pain and was really essential to managing my chronic dislocations. It was shocking for me when I found that there were specialists in what it was suspected I had, and I had to wait 2 to 4 years on wait lists before I could schedule, sometimes then wait in another 18 months or more to be seen. Not only did I go from healthy and athletic to completely disabled, but the system, I believed my entire life that was meant to help people like me in the situation I was in, it didn't. 8 years of decline, 6 years of disability later, I had a collection of rare diagnoses with no cures. Ehlers-Danlos syndrome, multiple rare skeletal structural anomalies, and neurological and immune dysfunctions were all combining to create the symptoms I was experiencing and contributing to my disability. But one of those conditions, mast cell activation disorder, became my linchpin. Because if I can manage my mast cells, and I can, then I can actually relieve most of the other symptoms that I experience. So this photo is of me trying out riding a bicycle a year into having maintained motor control of my legs after all of that time of not having them. And this really marked the beginning of not just my muscular rebuild, but also my nervous system rebuild and getting my body to actually listen to and coordinate again. So I think it's really important to emphasize that in my patient community, my decline, my diagnostic odyssey, disability, contraindicated medications, all of that is entirely normal. Nothing rare or unique about that. What's unusual about my experience is my recovery. And why? Like, why did I get better when so many of my friends and my peers can't? And part of it is, prior to my illness, I was a licensed massage therapist for 12 years. I actually worked as an injury rehabilitation and pain specialist. That made it so that I was able to work both in primary care and physical therapy clinics. So I have a higher than average medical literacy, especially about gross anatomy of the body. In addition to that, my husband provided me with unconditional support, including insisting that we pay out of pocket for the mobility aids that I needed. And at the time, that meant forearm crutches that were made of carbon fiber from Russia that you couldn't get at the time in the US, the wheelchair in the previous image. And he also would fly me across the country to attend conferences where I could network with those physicians whose wait list I had been on, cut in line to get access to vital information about how to best help myself recover. In my community leadership roles, I know hundreds and thousands of patients with my diagnoses. Some of them are local, some of them are statewide, national, and internationally. My recovery is unusual, but I don't believe it needs to be because my recovery didn't require rocket science. I had the financial privilege to work around a system that is not working for patients. I had access to essential information that allowed me to pursue relentlessly my own health. I went back to school and got a bachelor's degree in business and healthcare administration so that I could improve my advocacy on behalf of my patient communities. I am now in my master's degree in social work because I am trying to change the systems that aren't working for us. Which brings me back to the RDAC. When systems are not serving the people who are in them, it is policy work that is the best lever we can exercise in order to make changes. So the whole RDAC meets a couple times or a few times a year, but it's in our smaller subcommittees where we really get to work and we see each other more regularly. So I'm honored to co-chair our legislative committee with Marion First, who is standing next to me in this image. And we attend legislative hearings. During the general session, we meet weekly as a committee to discuss what our priorities are and what our responses are going to be to legislation that is either valuable to us or that we have concerns about. And some of our policy advocacy successes from the last year, we've been able to preserve the integrity of our newborn screening program, ensuring that all children born in Utah will be screened for treatable conditions, which is essential because some of these conditions, if you don't catch them before they start, there's really nothing to do. And we were able to advocate for policies that preserved this program. We've also been involved in supporting legislation that is going to reform pharmacy benefit managers, which is pretty essential for patient access to treatments, as well as Medicaid wraparound services to provide basic support for ADLs and really basic safety for our most disabled community members, as well as providing them the opportunity for financial upward mobility. And we've also been able to support multiple statewide advocacy and awareness programs. Our stakeholders and communication committee is chaired by Gina Zanuck and Sylvia Lamb, who are both here tonight, and they are responsible for our website, our social media presence, and providing essential education and community outreach. And our newsletter, which has actually just been headed up this year by Ron Day, who is also here this evening. And it's in community outreach that I feel like it's honestly like this is the most fun in the RDAC. So community members have been able to attend Canyon Rim Care's Day of Service, which happens annually. If you're interested in looking for a service project, come ask one of us about it. And we also go to different medical events and conferences and table in order to provide information about the RDAC and to just collaborate and meet others in the industry. Our Data and Challenges Committee is charged with collating data about Utah rare disease patients and identifying the challenges and barriers that we are experiencing to get care. And this committee, frankly, has truly like an apt name because data about rare diseases is incredibly challenging to find, largely because of systemic structural barriers. The reality that most diseases that are rare don't actually have a diagnosis code. If they do have a diagnosis code, it's not the same between systems. And so we're still looking at novel ways of approaching data to help inform our policy work, but we're also now developing a qualitative survey for directly asking our community members what it's like to be a rare disease patient in Utah. Because after all, everything the RDAC does is for our community. Whoops, back one. So I'm a member of the Rare Disease Advisory Council. For all of them, everyone in these photos is a Utahn. Every one of these families and individuals is impacted by rare disease. And I know many of them personally. And I know that most of them don't have diagnostic and treatment stories that end in riding a bicycle into the sunset. I want to change that. Comprehensive, complex care is very, very hard to find. Physicians frequently are afraid to work with patients like us. Institutions are concerned about the expense. I am thrilled about my internship at the Traeger Institute for Optimal Aging because we are actually using a tested, validated reimbursement and care treatment model for complex older adults. And I'm thrilled about the possibility in the future of transferring this model of care and reimbursement structures to extend it to the rare disease community of Utah, because complex care can be affordable, it can be lucrative, and it can be complete. So please come say hi to me, introduce yourself, especially if you're in the industry and want to network and talk about this and brainstorm, let's work together. And please follow the RDAC. Go visit our website, sign up for our newsletter, follow us on social media. Let's talk about how we can help more patients to thrive, especially when there isn't a cure. Thank you very much for your time.
Good evening, everyone. It's an honor for me to speak to you tonight. I'm probably a new face to many of you. My name's Quinlin. I am the chair and professor of human genetics at the University of Utah, and I come representing numerous researchers and clinicians at the University of Utah that work on the full spectrum of rare disease, everything from developing new technologies to find the genetic basis of rare disease to using cutting-edge technologies to develop new therapies. I'm going to give you an incredibly brief history of the history of advances in rare disease diagnosis and try to end with a vignette about a recent finding that I think offers a glimmer of hope regarding advances of the genetic diagnosis of rare disease. So I think probably many of you are familiar that the University of Utah has a long history in figuring out the genes and genetic changes that underlie many human diseases. Some of those gene discoveries are depicted in this word cloud here. And part of that history, in large part, that history is why I moved my lab here from the University of Virginia back in 2015. I've been working on the genetic basis of disease since 2008, and I was really excited about the opportunity to join some of the scientists that are listed on this paper here to advance technologies in pursuit of finding the genetic basis of disease. My training actually is in computer science. I had a long career in developing software for unrelated disciplines. But I got really excited about the opportunity to bring my skills to use big data and DNA sequencing technologies to advance gene discovery. And there was a seminal paper back in 2010 that defines something called exome sequencing. This is just a specialized technique that many of you are familiar with, where you can use DNA sequencing to focus on the critical parts of our genome that encode proteins and are typically connected to disease traits. And the underlying individuals that you certainly can't read in the back, those are some of my colleagues up at the U, including Lynn Jordy and Deb Nicholson, who I work with all the time. This is really the technology that set off the use of DNA sequencing technology at scale to understand the genetic basis of disease at Utah. And the same year, another advance was made with using whole genome sequencing, so looking not just at 2% of our genome that makes genes or makes proteins, but the entire genome. And that was also led by Lynn Jordy, and really underlies a lot of the kind of the state of the art today in terms of the molecular techniques that we use to try and understand what's going on. One of the things that we really specialize in at the University of Utah is the computational tools and the data science aspects of actually learning how to use these technologies to actually find the genetic changes that lead to different diseases. And that, as you probably are aware of or know intimately, that remains a huge challenge. At the University of Utah, even with state-of-the-art techniques, we typically only find the genetic basis of a rare disease for about 25% of patients. That's improving, but slowly. But the thing that really drives my research and a lot of that of my colleagues is the combination of state-of-the-art technologies, molecular technologies to sequence DNA and combine them with new computational techniques to squeeze every last drop that we can out of these technologies. And that's what excites me about the combination of these two things, along with trained scientists, are what drive discovery. But I'll be honest with you, most of what I do and what people in my lab and my colleagues around the world do is we get these results from these sequencing experiments, and we are often in the dark about what the cause is, and we develop techniques to essentially shine a flashlight throughout the genome and look at it in different ways to try and figure out what's going on. And this is an incredibly frustrating process, and the previous speaker touched upon the fact that, you know, with rare diseases, we don't have a lot of data. So often we don't even know where to look. We kind of have to look everywhere and hope that we see something that stands out to us. But these technologies, the combination of molecular techniques and computational tools, have led to numerous programs at the University of Utah, many of which you're probably familiar with, starting with the Utah Genome Project, the Utah Center for Genetic Discovery, which I co-direct. That's why I came out here 11 years ago. The Center for Genomic Medicine, the Penelope program, which I'm sure you're aware of, the Undiagnosed Diseases Network, the NeoSeq program, where we sequence the genomes of neonates in the NICU, and most recently, GeneKids. What I want to close with is some very recent, as in last week, advances led by a new faculty member that just started at the University of Utah in January. His name's Mitchell Volger. He came here from the University of Washington, where he led a program focused on advancing technologies to diagnose rare diseases. And what's so special about this story to me is it is a new faculty member working with a brand new grad student that came to his lab to learn how to use these technologies, and within 3 weeks figured something out that no one else in our department could figure out for a couple years. And it relates to a patient who had an undiagnosed but suspected case of either Prader-Willi or Angelman syndrome. Here's the clinical description. Initially, this patient and their parents had whole genome sequencing with sort of older technologies, and nothing obvious was found. But as part of a program that we have at the University of Utah called ReSeq, which is periodically we use new tools and new sequencing technologies to go back and revisit these undiagnosed cases to see if the new advances can uncover something that was previously undetected. And Mitt was one of the reasons, this is one of the first people that I've recruited as a new chair in our department. One of the reasons I was excited about bringing Mitchell is he has a completely different perspective about the computational and molecular approaches that we should use to study rare disease. And he published a really beautiful paper about this topic about a year ago. So his approach is to use a different DNA sequencing technology. It has a very fancy name, which is long read sequencing. It's just like, think of a big puzzle pieces for a jigsaw puzzle versus very small ones. And he uses that technology to both study genetic changes, but also so-called epigenetic changes, where there's different modifications to DNA that can change the way our genes function and lead to disease. I'm going to cut to the chase. He went back and looked at this patient in this part of the genome that's associated with Prader-Willi and Angelman syndrome, and saw something that hadn't been seen before. Let's see if I can walk over. So over here on the right, this is a slice of this individual's genome. On the top is, on the top and bottom are DNA from mother and father. And on the right-hand side, things look the way they should. I'm going to keep it simple that way. On the left-hand side is a nearby part of this region of the genome, and things should look identical to that on this side, but he noticed that things look different here. Both the maternal and the paternal DNA look the same, but they should actually look different. And this was only detectable with this new sequencing technology. And so this slide that I got from Walker, the graduate student, is just a couple days old, but it's a new candidate for what might actually be going on with this patient. It's not a smoking gun, it's not solved, but what I'm trying to highlight to you is how the combination of new perspectives, new techniques, and new algorithms and software nominate new potential genetic changes that underlie disease. So I bring this up because molecular and computational advances really are essential to driving disease. We at the University of Utah are really national leaders and international leaders in this. But I think one of the things that we're all struggling with nationally is that this requires substantial infrastructure, both in terms of sequencing technologies, computers, researchers, substantial expertise and funding to do this type of work. But what really excites me, having been in this field for almost 16 years, is that the technologies and both molecular and computational are really coming together in a way that, combined with the advocacy of this group and changes in policy, that we might be at a kind of a tipping point where we can start to develop larger cohorts of rare disease patients and trying to compare DNA sequences among them and phenotypes to make breakthroughs about what the genetic basis of these diseases are. So that brings me a lot of hope and excitement, and I hope that gives you a sense of some of the cutting edge research that's happening just a couple miles away. So thank you so much for your time.
Good evening, and thanks for the invitation to speak here tonight. I am Sally Jo Zussman, and I am a nurse by training. I am one of the senior directors of the Utah Data Coordinating Center at the University of Utah. I'm also a member of the RDAC. So what I want to also thank you for the placement, because everybody who's spoken up till this point is a great segue to what I'm going to talk to you about. And I want to talk to you about hope needs proof. So we've already heard a lot about the pieces towards moving towards questions and disease symptoms and undiagnosed conditions to solutions and hope. So how does hope needs proof, and how does research become evidence? I was actually asked to talk a little bit about the Utah Data Coordinating Center and where it fits in this whole idea of rare disease and what our part in the equation is. And so first of all, we are a data coordinating center, not a data center, not those big things that take up all the water that power AI. That's not what we are. We're the Utah Data Coordinating Center. But I got to tell you, they're not really a very sexy kind of thing to talk about. So talking about what a DCC, I'm going to talk about 3 aspects that will help you kind of understand why this is relevant to tonight. So first of all, I want to talk about why promising is not the same as proven. I want to talk about the Utah Data Coordinating Center, and since it's not very sexy, we're going to talk about it like a test kitchen. I'll tell you more about that in a minute. And then I want to touch on how patients and families and you all can change the trajectory of research. So first of all, we talk a lot about promise. We are about promising therapies, promising gene discoveries, promising compounds that are being developed all over the world and the country in terms of science. But you have to know that promise is not the same as proven. Promising sounds great, but it doesn't always turn into a cure or a treatment. So why is that? Well, in research, promising signals can look great, convincing, until we test them. And then we dig into the research and we find out, okay, put that one aside. That one didn't work out so good. So how do we do that? So hope needs proof, and proof needs evidence-based research. And that's where the Data Coordinating Center and researchers come into play. Delivering results from a clinical trial or an observational study or what have you sounds really easy until you find out that not everything with stripes is a zebra. So you might see something that looks really promising, like, oh, look, we might have something, just like the previous speakers have spoken about, but it may not be the cure that you're looking for. Why is that? So you've heard about some of the challenges in rare disease already tonight. Small populations of patients, varying time and symptoms of disease onset, an unknown course of disease, lots of different symptoms mushed together, as we've heard about tonight as well. How do you research that? How do you study that? And then finally, another factor in finding cures and hope is getting the right expertise for designing clinical trials for the population, and specifically for a rare disease population. So what is that process toward proven? So let's say you have a discovery or a compound or a drug or a device or a procedure that you think is going to help a certain population. In order to get it FDA approved, the FDA approval law requires, and this is a quote from FDA website, substantial evidence in 2 well-controlled clinical trials. Okay, there's a lot of criteria there that you have to meet. You have to have an appropriate study design that matches the research question you're trying to answer. You have to have a treatment group and a control group. You have to have an outcome or the result, the effect of what you're trying to study has to be well-defined and robust. Does anybody know what all that means? It's kind of tricky. Then you must have at least, or this is actually a change from the previous FDA requirement for 2 adequate clinical trials. Now they're talking about 1 trial plus confirmatory evidence. And that's all defined in great detail, as you might guess from the government. So how do you get a compound or a discovery all the way through this process? So that's where the Utah Data Coordinating Center comes in. And that's what my role is at the university, and very excited to tell you a little bit more about that. So we essentially have a group of 150 people who are experts in study design, in data collection, and in the conduct of clinical trials. We have 30 years of experience just sitting around nerding out, thinking about data and thinking about clinical trials and how do you take all this data and get some sort of an answer out of it. We've conducted or supported the conduct of over 200 studies, and many of those in rare or uncommon disease. And so our goal, our mission is to work with all kinds of people, investigators, companies, scientists, collaborators, people who have ideas or discoveries, and help them get that information that the FDA requires to turn that idea or that treatment into a proven or evidence-based cure. So I said we weren't very sexy, so we look like a data coordinating center, but that kind of means we're like a test kitchen. So why is that? Hope needs proof. Proof needs quality research. High quality research means thinking like a test kitchen. You know you can't reproduce a recipe, or you can't scale a recipe if you can't reproduce it, right? You can make the chocolate chip cookies once, but if they don't come out the same way and somebody else can't redo that same recipe, then you don't have an actual product. So we function as a test kitchen to support researchers who make the discoveries, and we help figure out how to turn them into evidence-based research. So just a few things that we do. We help write the recipe or that study design that you heard about that the FDA requires, a robust study design. We help figure out how a study should be designed, especially in a difficult rare disease population. How can that study be designed to get the answers that we need? Which patients should be enrolled? Which patients will be eligible? What does success actually look like in this study? And most importantly, how is safety managed? The next thing we do is we standardize the measuring like a test kitchen. In this case, we standardize data collection. So when you're looking to answer a research question, you can collect a lot of data, sometimes too much data. You can collect too little. You can collect the wrong kind of data. And what we do is help investigators, companies, researchers, scientists figure out what the right data is and how to collect that the best way. Then we keep the kitchen clean. That refers to data quality. So you can imagine in a big clinical trial where you found all these rare disease patients or difficult patient population to enroll, but now you have a lot of missing data. So how do you find out make sure the right data is in the database? You have all the data that you need to reach the conclusion. That is data quality and keeping the kitchen clean. And then finally, we do the taste test or the data analyses. So after all the data are collected, we translate thousands of points of data points into a trustworthy answer that can be used to answer the research question and help reach a cure or a treatment. Why? Because hope needs proof. So for example, let me sum that up for you in a little example here. You have study A. It's promising, but messy. Different sites, clinical sites, hospitals, clinics across the country, let's say, measured things differently. Their clinical practice differs at all of these different sites. There's missing data. There's inconsistent follow-up of patients. All the patients didn't come back in the right time frame. There are clinics with different procedures. The result of all of that is the study is over, but we still don't know the answer. So now let's look at study B. Proven strong evidence. There was a clear study plan and consistent measurement. There was safety monitoring and issues were caught early to protect patients. There's clean, analyzable data. The result is an answer that actually helps patients. So that's the very non-sexy test kitchen aspect of what the Utah Data Coordinating Center does. So now I want to touch on another topic briefly, how patients and family can change trajectories, because we're all about making change here tonight. And these are a couple quotes from the various papers and publications. You probably already know this. In rare disease research, even finding enough participants for a clinical trial can be challenging, and sample sizes are often so small that the FDA that warns that even a small amount of missing data can make results less reliable. So we at the Utah DCC, we see patients and families as partners. We like to explain the research and provide opportunities for patients and families to join trials. We often support patient advisory boards on how to make studies feasible and accessible for patients who have a condition. We involve patients in defining what matters to patients. Let's not study an outcome nobody cares about. Let's study an outcome that actually matters to the people with the condition. And then we share the results of clinical trials with patients. And I encourage you, if you leave this night with nothing else from me, it's to consider, can you find a clinical trial? Can you encourage your peers, your family, your community to join clinical trials? It's one of the ways we get answers. And finally, I want to introduce you to two people named Ivy and Bill. And this sort of sums up the process from promising to evidence-based or proven, as we'll say. So Ivy and Bill spoke at our Data Coordinating Center, our DCC conference this year, our all-hands meeting with about 150 of our staff. And they both are diagnosed with a condition called idiopathic normal pressure hydrocephalus. This onsets in older adults. It's kind of similar to baby hydrocephalus. But essentially, there's too much fluid on the brain. And the question is, what's the best way to alleviate that pressure without harming the patient? So we took that question to the scientists in one of our rare disease or uncommon disease networks. And this is what we did. Over the last 10 years, we thought about how to actually conduct this trial and enroll patients into this trial. We did a proof of concept study. We interacted with patients. We got NIH funding. And all of that led finally to a clinical trial that was positive and published in the New England Journal just recently in the past year, and showed the answer to the question, does this particular procedure actually help these patients? And the answer was a resounding yes. So the moral of the story is, with the test kitchen, with the patient support, with the idea of turning promising into proven, we can make a huge difference in rare disease. And I thank you for your time tonight.
Hi, my name's Tracy George. I'm the President of Innovation and Chief Scientific Officer at ARUP Laboratories. That's the largest nonprofit reference laboratory in the United States, and it's owned by the University of Utah. I'm a pathologist. I diagnose disease under the microscope and using labs. So why am I here? So 23 years ago, I was a young assistant professor at Stanford. And my colleague Jason Gottlieb and I saw our first patient with mast cell leukemia. It's a very rare type of systemic mastocytosis. I was happy to make the diagnosis. And my colleague, a hematologist, recognized that there was a promising new drug being developed for another purpose. And he said, you know what, Tracy, I think this will work in our patient. And it did. The FDA, was petitioned. We were able to use compassionate use, and we published that 2 years later. Jason started an investigator-initiated trial at Stanford, and I was the pathologist. Very rare disease at that time, hard to make these diagnoses. There was one expert pathologist in the world, and I went to meet him and train with him. Our results with this new drug were so promising, we presented at a scientific conference. It was in Budapest. And I remember because Jason showed the clinical data, I showed the pathology data, and the room just erupted. Because all these folks had been studying this disease, and we even knew the genetic mutation, so we were ahead of it. But there were no drugs that were available. The maker of the drug jumped on this. That was Novartis. We ended up with an international multi-center clinical trial, and that was the start of really my career as a clinical trialist. That drug was approved. We published it in the New England Journal of Medicine. And then, a few years later, another company came by. We were still studying the disease. The drug was partially effective. It was kind of a dirty tyrosine kinase inhibitor. Wasn't perfect, but it was better than nothing, right, that we'd had for these patients. Right now we had patients who were actually able to live longer. And this startup said, hey, we have a drug that we think is better. And it was. And I was the pathologist, again, on multiple clinical trials now with that drug for various types of the disease. And then now, a few years, about 5 years ago, the third company comes along. And this drug is even better. And now there's even more companies that are interested in this. And along the way, we've developed incredible therapies for people. So what have I done as a pathologist, right? I'm not the treating clinician. I diagnose diseases. And I recognized that there were research tests to diagnose this particular mutation in the KIT gene, but there was nothing that was available for patients, nothing that was available clinically. So ARUP developed a sensitive PCR assay to diagnose this test. And I knew if we launched this, it would force the other labs to do it as well. And that's exactly what's happened. And that was, maybe 4 or 5 years ago. And now we've developed additional genetic testing and even more superior genetic testing. And amazingly, we're finding this out, this rare disease, it's not so rare because we can actually test patients for it. We can test patients, we can identify them, but then we didn't have physicians who could treat them, right? It's so rare. Patients were waiting years to get treatments. What Justine said really rang true. So in 2019, my colleague Jason Gottlieb, Jem Aiken, an allergist, Mariana Castells, another allergist, Melody Carter, another allergist at the NIH, we've co-founded the American Initiative in Mast Cell Diseases, dedicated to forming centers of excellence for these rare diseases, mast cell diseases, across the Americas. That was 7 years ago. We now have more than 30 such centers. We're having our biannual meeting at the University of Michigan this year. We've got incredible numbers of scientific abstracts, and we're educating different types of physicians on how to diagnose this rare disease. And I'm really proud to be a part of this as a pathologist. And that's been my passion, is rare diseases. And that's why I'm at ARUP. And when I came 8 years ago, and they're like, what do you want to do, besides your pathology day work? I said, you've got clinical trials and pharma work? I go, that's the group I want to run because I know the power that you can do with these groups. So that's ARUP. We have more than 3,200 tests and test combinations. There are more than 100 people like me, including those in the audience here. I see several of them. And they're all experts in different areas of laboratory medicine. Most of our testing is performed in-house. It's of the highest quality. We support more than 8 million patients each year in all 50 states. And we're not really restricted to the US. We do an incredible amount of research and support clinical trials around the world. We just announced actually last month, and I put flyers down, we launched a new innovation central laboratory. We have more than 70 laboratories because of so much testing we do. But this innovation central laboratory allows us to take research and accelerate it into clinical tests for patients and offer it quickly. First, maybe for clinical trials, and then eventually into patient use. So this is allowing us to validate technologies and expedite the development of assays, especially for rare and under-recognized diseases. What type of diseases, what types of technology? Well, that NeoSeq, yeah, that was my colleagues at ARUP who partnered in that. Whole genome sequencing for sick neonates so that we can get an answer for at least some of those patients why they're sick in less than a week. We have a broad portfolio of very specialized genetic and molecular testing, and there's a lot of deep expertise. We've delivered the first of its kind companion diagnostics for gene therapy assay for hemophilia. And we offer now other companion diagnostics because the FDA requires for some diseases, I'm sure many of you know, that you have to have a test that identifies that you're a candidate for that drug for that disease. And we have experts that do that. Why do we do rare diseases? Because the big companies won't do it. There's not enough profit in it for them. But we don't care because every patient deserves a diagnosis and a treatment. And that's why we're committed to that. And when I took over as CSO, I thought it was really important for innovation that there's incredible scientists everywhere, both in academics, but also in industry. And I've partnered with industry my entire career, and that's how I've done my research. And so at ARUP, we've been able to do that. We partner not just with academic centers, but with promising industry partners as well. And does it work? Yes, if they share our mission, if they prioritize patients first. So we're located like just down the road, right, in Research Park. We're almost 5,000 people here, and it is an amazing team of people. And our passion is helping patients. And so when Gina said, do you want to come back for Rare Disease Days? I was like, absolutely. Thank you very much.
Okay, wow. What a great night. What an all-star lineup of speakers. I don't know what I'm doing here. I wrote on the top of my paper, sound smarter. That's what I wrote. So thank you all for the work that you do. Thank you for existing. It's really making a difference, and I hope I can do justice following you all, but I'm grateful for you guys for taking time out of your day to be here with us all. My name's Stacey Allen, and I was asked to speak a little bit about my journey as a mom. And when I heard the theme for tonight, which is an evening of hope, I just love that because I love the word hope. And it really captures the story that I've been living in my own personal life. So I'm excited to get to speak with you guys a little bit about it. But if I could, I wanted to twist my thoughts a little bit around hope and share with you an idea that is a Stacy term, as I like to say, but it's called courageous hope. And I hold on to that because it ties an action to the word hope. Courageous hope isn't soft, it isn't passive, it's action taken before answers exist. Oh, nope. Do I just push? Yeah, Any idea? It just goes to that one. Sorry, I broke it. Yes, I can keep going while you fix it, if that's okay, so I don't. Okay, she's coming. I emailed the link to you and Emma. This is gonna be really boring if I don't have any slides, guys. Okay. 5-minute break. All right, 5-minute breather, stretch. Okay, welcome back. Gina, the boss, told me we got to get going. Hopefully that was a nice stretch. Got up and got a minute to stretch. So 2 more speakers to go. You're almost done. Anyway, Stacey Allen, I'm going to speak on courageous hope. I'm so sorry. Of course, that would happen to me. So this is why I wanted the slides. This is my family. My husband, McKay, and I, we have 2 boys. Our oldest is 14, and our youngest, Jackson's our oldest. He's 14. Evan, our youngest, is 12. We love to travel. We love BYU. I better be careful saying that too loud in this crowd. Yay, okay, we got a few. And most of our lives are spent on football fields and lacrosse sidelines. So my oldest actually had his first game tonight for his high school career. He's a lacrosse goalie. It's not going well, so I chose, well, being here. Both of our boys actually have their own unique medical journeys, but tonight I'm going to center my thoughts around my youngest and his journey, and my journey as his mom. In 1938, I'm sorry, I'm really going to get this. Okay, in 1938, Dr. Dorothy Anderson published a landmark paper describing a condition she called cystic fibrosis of the pancreas. Before her work, children with cystic fibrosis, or CF, were misdiagnosed with malnutrition or often celiac disease. Through careful, painstaking autopsy research, she connected the symptoms into a single disease entity, calling it cystic fibrosis. She didn't have treatments, she didn't have a cure, she had clarity and courage. Her work reminds us that courageous hope is the willingness to look directly at hard truth and act anyway. In 1950, Evelyn and Milton Grob were told that their infant son, diagnosed with CF, would not live past the age of 5. There was no research, no treatment, and no roadmap. Evelyn refused to accept that outcome as a mother. Without internet, without community networks, and without even knowing where to start, for 18 months, she waited outside doctors' offices and in the parking lots of doctors' offices when she was kicked out of the offices themselves in Philadelphia, stopping parents as they left, asking if their children might have similar symptoms to hers. She was kicked out, but she kept going. By 1955, that small group of parents founded what would then become the Cystic Fibrosis Foundation. That wasn't hope as a feeling, that was hope expressed through action before answers existed. Over the decades, that courageous hope built infrastructure. In 1961, accredited CF care centers were created. In 1966, the CF patient registry began, turning lived experience into measurable progress. Parents believed if we can track it, we can improve it, and they were right. In 1989, foundation-funded scientists identified the CF gene. For the first time, CF wasn't just a collection of symptoms, it had a target. Hope surged, but discovery doesn't often equal care or cure. So families continued fundraising, they continued advocating, they continued pushing science forward. In 2000, when pharmaceutical companies hesitated because CF was rare and expensive, the CF Foundation invested $40 million of that hard-earned fundraising dollars by parents in Aurora Biosciences to pursue a radical idea. Let's just fix the broken CFTR protein itself. There were no guarantees, there was no precedence, just belief backed by action. That is courageous hope. In 2012, it paid off. The first CFTR modulator, Kalydeco, was approved. It worked for a small percentage of patients, but it proved something critical. CF could be treated at its source. The impossible had become possible. 1 year later, in 2013, our son Evan was diagnosed with CF through the newborn screening at 6 weeks old. We walked into Primary Children's Hospital overwhelmed, terrified, and grieving the life we thought we would have. We learned that day that CF was progressive. Evan would get worse as he got older, that the median life expectancy at that time was 36 years old, and that he would require more than an hour of daily lung therapy and 20+ pills to live some semblance of a normal life. It was shocking, it was heartbreaking, it was heavy beyond measure. And then our doctor said something that I'll never forget. He said, "For the first time in CF history, there is hope." That was his exact sentence. There were medications in development, there were trials underway, there was momentum. He said, "Hold on to that hope." So we did. Courageous hope for us began quickly. We chose to engage deeply, intentionally, relentlessly. We connected with our local CF Foundation chapter. We read everything. We attended scientific conferences. We met researchers and asked the hard questions. We fundraised, luau's, walks, galas, golf tournaments, you name it, we're there. We shared Evan's story over and over. We hoped for something better than a steady decline. We learned Evan might qualify for a clinical trial connected to the very research decades of families had funded before us, so we aimed for that future. In 2017, Evan began a 3-year clinical trial at Stanford. He was 2.5 years old. He endured more procedures, blood draws, travel, and disruption than any toddler should. But he did it, and we did it, because contributing to the science that could change not just his life, but others mattered deeply to us. Those years were not easy. CF still dominated our lives. Daily therapies, multiple hospitalizations, appointments layered on appointments. We saw progress, but we still lived in tension. In 2021, our miracle came. Trikafta, an improved drug to the one that Evan participated in the clinical trial for, was approved for Evan's age group. Nearly 90% of people with CF became eligible for this transformational medication that addresses the root cause of the disease. Today, children born with CF are predicted to live into their 60s and beyond, assuming access to therapy. Evan is living a life that we only once dreamed of. He plays football, he plays lacrosse, he's hiked the Alps of Switzerland, he's stood on the equator in Africa, he's ridden camels in Egypt. He now worries more about whether BYU will win than about his next hospital stay. CF hasn't disappeared, but it no longer dictates every moment. And I added this in because I really want to be sensitive here to the thoughts that have been shared before and recognizing the privilege and the blessing that this is. I recognize that not everybody has this, and we were fortunate enough that Evan was born in a time that we benefited from all of the research and all of the hard work that went before us. So I really want to recognize that hopefully my words are coming sensitive to that blessing and that privilege that we've lived. So circling back to what I was actually asked to speak about tonight, and that's my journey as Evan's mom. It has been and will continue to be the greatest adventure of my life. And here's what I've learned. Say yes. I've said yes to a lot of things that have taken me out of my comfort zone, sharing our story, serving on advisory boards, participating in quality improvement initiatives, becoming a certified quality improvement coach, serving on national committees, co-authoring and recently first authoring a published medical manuscript, speaking about policy and change locally and in DC, not because I planned this path or have a background or formal degree in anything medically related at all, and not because it was comfortable, but because courageous hope reveals itself one step at a time, and every small action compounds. Courageous hope doesn't end with breakthrough. With one of CF medications costing more than $327,000 per year, access and affordability is now my fight. So I keep saying yes. I say yes to policy, yes to insurance and advocacy, yes to system level change. And this path has led me to recently getting a job in clinical excellence as Primary Children's Hospital, helping to try to bridge patients, families, and leaders to improve care. Because the story of rare disease is not finished. I'm not going anywhere, not just for Evan, but for everybody in this room. And my dream is not finished. I still courageously hope for a cure for my son and know that that day will come. And I will not stop acting and saying yes until it does. Erin, I wanted to kind of shout out really quickly. Your remarks reminded me of a conversation that I had at our first scientific conference that we went to when Evan was diagnosed. We met with the lead researcher at the time and we said, okay, we know that, can we get there? Can we really get to this cure? And he said, technology needs to catch up to what we know science can do. And your thoughts just beautifully reflected that of, it's been amazing to see over Evan's 12 years that technology catch up to being able to do what we know science can take us, where science can take us. So I really appreciated your remarks. The story of cystic fibrosis is not a story of waiting quietly. It is a story of parents who stood in hallways, scientists who worked without guarantees, clinicians who believed before proof, patients who endured before cure. It is a story of courageous hope. Hope that acts, hope that invests, hope that organizes, and hope that shows up. And tonight, that is my message to all of us. Courageous hope is not reserved for medical breakthroughs. It lives in the choices we make every day. When we speak up, when we participate, when we advocate, when we say yes, when we refuse to accept good enough. The answers we celebrate today exist because someone decades ago acted before the answers existed. So whatever rare disease brought you here tonight, your voice matters, your actions matter, your courage matters, because the next breakthrough is already being built by people in rooms just like this one. Thank you so much.
Oh no, let's go to the next slide. Okay. Let's get this settled. All right. There we go. All right. Well, hello everyone. My name is Januel Gomez Colon. I'm here to tell about my story. And my story doesn't start in Utah. It starts on a small island in the Caribbean. It's 35 miles wide, 100 miles long. You may have heard and seen the story of this island during the Super Bowl, this island being Puerto Rico. My parents were attending college on the island when I was an infant. They noticed that I wasn't developing at the right rate. For months, my parents, they noticed that I was quiet. I wouldn't crawl and I wouldn't sit. They went to the doctors to find answers, only to find none. For months, my parents went to different specialists to figure out what my condition was. Guesses to why I had ranged from cerebral palsy to ALS. Then they went to a genetic specialist who confirmed I have spinal muscular atrophy, also known as SMA. SMA is a rare genetic condition that's caused by a genetic mutation in the genomic sequence. It causes the body to not be able to produce proteins needed for survival for the muscles. It has various ranges from type 1 to type 4. I was a type 2. The second most severe. When I was diagnosed, I had a terminal life expectancy of 7 years. My parents refused this reality. Being in college, they dropped out. They sold everything, and they moved to Utah because there were clinical trials hosted by the neuromuscular department. There I received treatment, trying out various drugs, therapies, trying anything for a cure. We were also didn't have a home. And so I was welcomed by the Ronald McDonald House for a year and a half until my parents could get a job because I didn't speak English. From the community to the researchers to clinicians to the physical therapists to my friends and my neighbors, that support led me to live a good life. I made it to my 7th birthday healthy and especially happy because I had Pokemon cards. However, without a true treatment, my body was still deteriorating. So I needed to keep hoping. I continued participating in various clinical research trials until the fateful day finally came. It was December 23rd, 2016. I was on my phone. I was in 8th grade. So I was on Christmas break. I was on my phone. I was watching Minecraft on YouTube. When I got an email from QRSMA, it said that Biogen received the first FDA approval for SMA. I remember reading it multiple times because I couldn't believe it. And I was just shocked. I was like, is this real? And it was through that the treatment came new possibilities of hope. I felt like I was no longer tied to my condition. And so I lived. I wanted to try everything, and so I did. In high school, I became a pole vault coach. I taught students how to jump over a 14-foot bar, even though I couldn't stand. We ended up sweeping regionals. I then graduated high school and returned to University of Utah, this time not as a patient, but as a student. Here, I had lots of success. My sophomore year, I collaborated with the NBA during All-Star Weekend. I reached out to them during New Year's Eve, and they responded saying, sure, let's collaborate. Let's do a community event together. I also got the opportunity during All-Star Weekend to coach celebrities how to jump higher, which was astounding for me for someone who never walked. I also got to create a healthcare club at a business school. I'm not a good researcher. I'm not a good programmer. I'm good at business though. And so I created a club to help students get into healthcare from a business side. That club ended up becoming a BioHive student chapter. And Kelvyn was actually one of the first speakers that we had before I even knew about the RDAC. I interned at incredible companies. I'm currently at Goldman Sachs. I even got to intern at an MIT spin-off lab that, going back to Minecraft, created the first ever AI civilization through Minecraft bots. In a full circle moment, 2 years ago, on March 4th of 2024, I was actually here for a school project. I didn't know about Rare Disease Day. I was here working with Roberston, who at the time was the chief business officer of Recursion. And that was an incredible opportunity just because I reached out. But my success wasn't just for me. I wasn't the only one achieving success. A few years ago, I went to my first QRSMA conference in Florida. There, on the first day, I was having lunch with my family. And there was this little kid running around. And his mom was sitting next to us. And so we asked her, like, hey, is that your kid who's the one with SMA? And she said, oh, it's the little boy running around. He's around 4 years old. And so we asked, oh, is he a type 3 or 4? And she said, no, he's a type 2. He has the same condition I have. But because of treatment, he wouldn't have the same burden on his body that I have. And it was beautiful. But there is still reason to need hope. As I was approaching graduation from the U, I was inducted into the BioHive Honor Society. It was the highest honor a graduate at the University of Utah could get. The ceremony was held in the Eccles Alumni Building. If you've ever been, it's a beautiful building. 1 week later, in that very same room that I was in, receiving my honor, Primary Children's Hospital held a memorial. I love volunteering at Primary Children's Hospital. It's my way of giving back to the community. And so, of course, I said yes to volunteering there. At this event, we honored the lives of 65 wonderful children who sadly passed away that year. Many of these kids had rare diseases, and some I knew from my time volunteering. In the same room that I received one of the greatest honors of my life, I witnessed the heaviest pain that rare disease can deliver. I was graduating college, and they never will. I remember asking myself, why me? Why couldn't they also get treatment and get the chance to love college like I did? To experience the great things, the friends, going to class. That's the hard thing about hope. It sits as a reminder that we are not where we want to be, that we need to wish for a miracle. But without hope, there is no push for progress. We do not attempt to do what we think was someday impossible. Without hope, we do not fight tooth and nail for an answer. We might not find a cure for ourselves, but we cannot stop moving forward for future generations. We have to hope that one day, every kid can run around without the burden of their condition. And so, at the end of this, I want to ask everyone this. For your loved ones, for the community, and for yourself. Keep your hope strong. Have courageous hope. and keep fighting. Thank you.
I just wanted to say quickly, the last few speakers hit my heart. I can't really speak right now, so it's just really quickly, but thank you so much, all of you. As you know, the ones that know me, I cry a lot, but everybody's speech was just so wonderful, and what a room this is to be at and to be a part of this, and thank you, Recursion, for everything, and everyone in the room. That's all, just thank you. Thank you from my heart.
I'm a huge crier too, so we'll be in good company. I just wanted to appreciate the vulnerability that you've all sharing your stories, the conversations at the break. I'm gonna make this quick so you can have lots more conversations. What I really appreciated was just the different places and perspectives and energies and talents that we're all bringing into this conversation, because we all have different experiences, and hearing about patients' experiences and families and advocates and the computational work that's happening at the U and the science that's happening at ARUP, it's really inspiring. And I hope that you're leaving tonight with a sense of optimism, with all the different flavors of hope that have been shared, however that lands with you. And my biggest hope is that as we close out the night, you'll make a connection with someone that you don't know as well, or someone that you've spoken to once, and that's gonna spark energy, and that's gonna spark momentum, and that when we reconvene here next year for the fifth Rare Disease Day, we'll be sharing more progress and more impact. So thank you so much for joining everyone tonight. Please enjoy food, conversations, and thank you again. Take care.